Please welcome the president of the McKnight Foundation, Kate Wolford.
Good afternoon and welcome back, everyone. Thanks so much for coming in at 1:15. I wanted to do one housekeeping note, which is to say that indeed your program, the printed program, said 2 p.m., which was the time that we thought when this was put to bed in the print version. But of course, we've had such a fabulous lineup of speakers coming here this afternoon that we are starting at 1:15 and we'll follow through with the program as you see the names listed. So again, thanks everyone for cutting your break short to be back with us. My name is Kate Wolford, and I serve as the president of the McKnight Foundation, which is a family foundation based here in Minnesota and established in 1953. It was founded by William and Maud McKnight, and William McKnight was one of the early leaders of the dynamic and innovative 3M Corporation. He served as its CEO and its chair, and then left a legacy which formed the McKnight Foundation. Today, our foundation is governed by fourth-generation descendants of William and Maud, as well as respected community leaders. Our current program areas span education, the environment, the arts, accelerating the transition to an inclusive and low-carbon economy, and also building our civic infrastructure. Like every organization engaged here at the MANOVA Summit, we work each and every day to build our innovation muscles so that we have the capacity to help bring forward a more abundant, just, and creative future for people and the planet which we inhabit. Today, it's my honor to introduce our next speaker, Dr. Ray Price. One way to introduce him is to list his credentials, and let me start with that. He is the director of the Center for Global Surgery at the University of Utah, and he is a surgical specialist at Intermountain Healthcare based in Salt Lake City. But his story is so much richer. After completing medical school at Harvard, he first developed a passion for global medicine as a missionary in Thailand, where he spent 2 years. Since then, his medical and surgical work has taken him across Asia, Latin America, the Caribbean, and Africa. Dr. Price and his team perform complex surgical procedures in what are economically resource-constrained places, using technology to both deliver care and to teach local providers in these quality procedures. He believes, and you're going to learn about why he believes this, that we can learn a great deal by studying the innovations that bring access and affordability to healthcare around the world. Please join me in welcoming Dr. Ray Price to the MANOVA Summit.
Thanks. Well, thank you so very much, and I'm thrilled to be able to come and speak to you a little bit, and I'll be a little bit similar but different focus. And I'd like to begin just by mentioning that I'm a surgeon, and people ask me, what kind of surgeon are you? And I respond, I'm a good one. We leave that up to my patients to decide. But then I go on to explain that I have an opportunity to do a very broad range of general surgery, from trauma surgery to surgical oncology to taking out your appendix. As surgeons, we have a unique opportunity to work with people to help them through some of their most difficult challenges. And as we work with them through some of their difficult challenges, these are sometimes at the most vulnerable times in their lives, and they have significant problems that they have to deal with. Do we have the slides that are up? I know the slides worked, we just worked through them. So if we could have the slides up, and while the slides are coming up, I'd like to, there we go. I'd like to start off first by sharing a note from one of my patients. And some of you may have had this kind of feeling in your life as well. Last fall, after recovering from surgery and several infections and the effects of 2 treatments of chemotherapy for my rectal cancer, I felt lost and almost hopeless. I was preparing to die, and not very happy about it. I would see myself sitting in a dark, small boat on a lake, Everything around me was dark. Like nighttime as any lake would be, I was completely alone. No one around. The boat was out on the lake, just far enough to clearly see the shore on several sides. But I had no way of getting to it. As I looked around, I realized that I couldn't reach it. I was adrift and began to feel as though I never would reach it. I've had a great deal of love, support, and encouragement from many sources. But there have been very few individuals who have been able to help me see the shoreline as something I can reach. Few who have been able to give me any secure feelings and any real hope. To you, any known form of appreciation doesn't seem enough to cover my gratitude for all that you have provided me. Yet I feel a strong desire to say, thank you. Thank you for helping me to feel as though I can reach the shore. Isn't this truly what healthcare is about? It's about the patient. It's about how we can help them have hope for what they are going through. Sure, it's about curing disease, but isn't it really about caring for patients? And what I'd like to ask is, well, where's the hope for the 5 billion people that don't have access to timely surgical care? The Lancet Commission in Global Surgery came out in 2015, identified there are 5 billion people that don't have access to timely surgical care. Like this man, that if the tumor had been found early enough, could have been cured. But by the time he has treatment, there's nothing anybody can really do. What impact does that have on his family as they need to go on in life and the economic problems that this causes? There are 18 million people who die each year as a result of surgically treatable diseases. Whether it's a meningomyelocele in a little pediatric patient, or in this middle patient, that's actually not his leg's behind there, that's his hernia. In Africa, we call hernias, they're either above the knee or below the knee. Unfortunately, this was in my office in Salt Lake City. We have an access problem in our own country. Or breast cancer, where it's occurring in stage 4 disease. Yes, this is Haiti, but I had a very similar patient in my office just recently. There are more people dying from trauma in the world than malaria, HIV, and TB combined. And then in addition, there are up to 50 million people that are having non-fatal disabling injuries. Here's a young girl in Ethiopia, came to our little clinic. As she limped in, had been hit by a car. We heard about auto pedestrian accidents. She's one of those. And she had an open tib-fib fracture that was treated inappropriately. And now she has a chronic infection. She actually probably needs to have an amputation, but she goes through life limping with a chronic infection. You know, there are many people that have said surgical care is too expensive to implement in low middle-income countries, especially when competing with other types of interventions to improve health, like clean water and sanitation, infectious diseases. However, in today's world, non-communicable diseases now outpace infectious diseases. And so if we're going to make any improvements in the future in public health, we need to start looking at non-communicable diseases. Most of those need care through surgical care. Dr. Kim at the World Bank made this comment, and I think this is extremely important as a new horizon to look at. We have to think in a fundamentally different way about health care and surgery's role in it. Not only is improving access to surgery the right thing to do morally, but it is also important to ending extreme poverty and boosting shared prosperity. Now, many people up until just recently have thought surgery is just too expensive. We can't do that. This is a new horizon. What can surgery do to actually improve economies around the world? This new horizon, a new vision. Actually, there's 4 areas. I'm going to kind of touch on each of these through a story. But surgery can actually be used to strengthen the healthcare system. Not just surgery itself. It's not just going out and doing surgery to help people. What can developing a surgical system do to strengthen the entire healthcare system? Surgery should be looked upon as an investment, not a cost. We'll talk about that. And then innovations that target low and middle income countries so that surgery can be available there is a new wide opening field. How can we partner together to make that happen? I'm going to use an example of gallbladder disease, and I can't see out there, so you don't have to raise your hands, but you can think, how many of you have ever had an operation either to have your gallbladder out, your appendix out, maybe an ovary worked on through little holes, laparoscopic surgery? In our country, you can go in and have your gallbladder out, and you can come home the same day, and then you're back to work somewhere between 4 to 7 days after surgery. Whereas most of the world still has to have that big incision down the side. They're out of work for 3 to 6 weeks. They actually might have a much higher rate of infections. Now, people had said, they even wrote articles saying, we shouldn't teach laparoscopic surgery in developing countries. No, those poor people, it's okay for them to have a big incision. They can take more time to get better. That seems like a huge disparity that needs to be overcome. So the story I'm going to tell you about is in Mongolia. And everybody asks, how in the world did you start going to Mongolia? Now, I go to many places in the world, but Mongolia was the place that my parents used to threaten to send me if I misbehave. It was cold, it was very barren, so when a director of a foundation heard of the work I was doing and invited me to come to Mongolia, I said, no, I don't want to go to Mongolia. I want to go to Thailand. I speak Thai, not Mongolian. And he said, we'll just be there for 1 more year and then we'll be in Cambodia. The foundation's not there anymore, and 13 years later, I'm still there. So, when I first went there, I was on the National Committee on Trauma here in the United States with the American College of Surgeons, and they said, you need to come teach trauma. And I was saying, well, geez, trauma. Okay, so I went there and didn't get much buy-in. But I got invited over to the university, and the university, there was this chief of surgery, the smartest woman that I've ever met. At that time, I thought she was crazy, because she told me this story about Buck Rusher, who came over and helped start laparoscopic surgery in Mongolia in 1994. But by 2005, only 2% of the gallbladders were being removed this way. They had a huge amount of disease, and it was only being done in the capital city. And then she went on to make this statement. Introduction and further development of laparoscopic surgery in Mongolian surgical practice is demanded. Now, I had just spent 2 weeks seeing what they didn't have, like clean water and electricity that was constant. It's like, how in the world do you think you can do that? I was of this other vision that, no, maybe they can't have that. But we began to think, how can we make this happen? So we went ahead and we began to develop. What are the resources we need? It wasn't just about doing surgery. You have to set up the whole system. So we did. We partnered with industry, with Mrs. Stortz, who was phenomenal and had a vision of what could happen. Ethicon, Covidian, Cardinal Health, many companies. We then had to come up with a focused educational content, translated into Mongolian. Nobody spoke English. And then we had to come up with a system. Could we teach a surgeon who had never done it before how to do it in 2 weeks? By the time we left, that they could do it on their own? Well, we didn't know. So then we brought in the University of Utah and their academic component. Let's study it. Let's study it when we went up to Erdenet, the first place outside the capital. Let's study it for 18 months. Let's look at the outcomes and compare it to where they had been doing for the first 10 years. And there was no difference in the outcomes. I'd like to share with you quickly a short video.
Намайг алтан сүхгэдгүй. За энэ хэвээр гамалтайгаа нутгалдаг хүн байна. Гэхдээ одоо нэг хөдөлгөөний бүтээч ч одоо энэ 4 цагийн иргэл одоо мал хуугаа хараад л одоо ямар цавгүй хүүгөөч хутнгаа сургууль соёлын мөргөө явцаад тэгээд энэ 2-3 сар 3-4 сарын юм л одоо энэ аюулхай орчмоор өвдөөл тэгэл энэ шигээ ингэж янгиж цээж их орсон. Тостоо хөхтэй юм идээд л тий. Зөр унаа явж хат нэг жоохон шогшиж мөгшөө ихээр их л огшиж өвдөж байна. Саяхан нэг 14 хоногийн өмнө нэг аймгийн төв ороод тэр мэс заслын гараад тэр дурангийн мэс заслаг тэр нав. Дурангийн мэс заслаг тэгэл одоо хийлгэж байгаа. Тийм санаатай л байгаа.
За Монгол улсад дурангийн мэслийг хөгжүүлэх шаардлага зүй ёсоор оргон гарч байгаа. За энэ одоо хөгжөөд 20 гаруй жил болж байгаа ч гэсэн зарим талаараа одоо багад тоног төхөөрөмж нь хуучирсан, эмчнэр нь одоо солигддог, залуу боловсон хүчин
гартлаар хүмүүсийн ойлголтаараа дутуу байсан. Дээрээс нь аппарат тоног төхөөрөмжтэй холбоотой асуудлуудаас гардгаас дурангийн хаалганы тоо бага байсан баг. Одоо бол дурангийн хаалганы тоо нэмэгдэх хандлагатай байгаа. Ер нь нэмэгдэх жоох гэж бодож байгаа.
Ер нь бол маш их үр дүнтэй ач холбогдолтой ийм арга байгаа. Сүүлийн үеийн дэвшилт технологи байгаа. Тэгээ энэ бол улам цаашаа хөгжих баг.
Мэдээж одоо өвчтөнд өөртөө зовир шаналгаа багтай. Дээрээс нь ажлаа хурдан хийх боломж нэгдэж байгаа.
Одоо боосахын сорин морог үлдэхгүй.
We are excited to be broadcasting live a laparoscopic cholecystectomy from Mongolia.
За энэ удаагийн дурангийн мэслийн сургалтыг явуулахад Америкийн нэгдсэн улсын Юта мужийн их сургууль, за Монгол улсын анагаахын шинжилгээ ухааны үндэсний их сургуулийн мэс заслын тэнхэм, Монголын дурангийн мэсэлчдийн нийгэмлэг, дээр нь Төв аймгийн нэгдсэн эмнэлгийн баг хамт олон одоо хамтарч ажиллаж сургалтыг зохион байгууллаа.
Grasping the base of the gallbladder. Music, can you show where the duodenum is?
За дурангийн мэслийн тусламж үйлчилгээг сайжруулснаар энд бол мэдээж одоо тэнд ажиллаж байгаа түүнийг хэрэгжүүлж байгаа хөдөөгийн орон нутгийн эмч сувилагч нарын мэрэгжил чадвар дэвшлэхээс гадна тэнд амьдарч байгаа иргэдэд одоо дурангийн одоо өндөр технологийн мэс заслыг газар дээр нь үзүүлж ирснээр одоо илүү ач холбогдолтой гэж үзэж байна.
So, I'd like to thank my program manager who I took to Mongolia. I said, can you please get some good video and make a video for me so we can show people what we're doing. Setting up laparoscopy. This is just an example. I could have chosen liver transplant. I could have chosen emergency and essential surgical care, the various projects we're working around the world. But they have the same concepts. Here, how do you continue the training? If you're going to train surgeons, how do you get it into their training program? So we sat down and said, let's train the trainer course in 2009. And from that, we then get the president of the Mongolian Laparoscopic Surgical Society, who becomes the director of laparoscopic training for the Mongolian National University of Medical Sciences. And as we do this, this is a cooperative program. Again, working with industry, working with academics, working with a foundation, working with the university there in Mongolia. During that first training, we showed them how to hook the operating room up to a conference room like where you could have 100 people. And you could watch them do the operation, and you could have two-way communication. When I showed up a few years later, they said, Dr. Price, come see your vision. So what are you talking about? Come see your vision. They took me to this place. Wonderful place that has places where they can practice doing the skills, where they can see the operating room exactly like we showed them. Now the residents spend 1 month out of all their training in this center learning laparoscopic surgery. What's happened as we have worked with not just teaching surgeons, but building the industry to support it, to have Mrs. Storts bring her representatives from Moscow and Irkutsk to figure out how we develop the supply line. And we set one of the surgeons up to be the distributor for Covidian. Improving surgical care in Mongolia, a sustainable model for development. Our teams taught in the maroon areas. Our students and their teams taught in the blue areas. And laparoscopy is now available in 17 of 21 provinces. It's now, in 2011, became the primary way to remove the gallbladder, benefiting the people in Mongolia. It's now up to 80% in the country. It's been a countrywide transition. I asked my wife the one time that she came, she hasn't gone back again, she slept on the plywood, but I said, can you go out and get the story of a Yun Bayar, a 24-year-old young lady who had to have her gallbladder out. These are the pictures of her 4 days after her surgery, milking her horse, making her yogurt. We put this together in a book, a whole story for the Ministry of Health, so that now they have seen the benefit that they now fund laparoscopic surgery for their people in Mongolia. What's happened? From a time when only a couple people were doing laparoscopic surgery in Mongolia to just This year was the 3rd Congress of Laparoscopic and Endoscopic Surgery. Can we make a difference by using collective impact to build health care? The Lancet Commission on Global Surgery estimate there's going to be a $12 trillion loss to economies of low and middle-income countries around the world by 2030 if surgery is not addressed. But if we were to invest up to about $420 billion, we could offset that amount of money. And if you could just increase surgical output, like was done in Mongolia, is what they said, 8.9%, we could save that money. What does that mean? For every $10, or $10 is generated in economic productivity for every dollar spent on strengthening surgical capacity. Now, 90% of the products and services that have been designed and engineered benefit only about 10% of the world's population. It's so fun to, I do robotic surgery. It's been fun to use the robot. It tells the laparoscope. I can tell the instruments what to do sitting at a little console. I can have greater use in my hands. But that's not going to make it in a lot of these areas right away. What can we do to actually expand health care that's affordable and available to the world? Not just to 90%, or not just to 10% of the population. When you look at laparoscopy, what's the global market overview? Well, right now there's about 4.4 million laparoscopic surgeries being done in the US, 7.5 million worldwide. 90% of those are being done in the US and Europe, not in most of the countries that really need to have it. There's an estimated 50 million cases per year additional unmet need in the developing market. And as you look at that World Bank income groups, there's been a change. People are going from the red to the orange area, orange to the yellow area. Countries are increasing their economic capacity. Thailand wants to become a high-income country. That's one of their main goals right now. So the challenge is, how do we design equipment that's high quality, yet extremely affordable, and to work in these kind of environments? This is looking out the window of the Hoved Hospital at the town of Hoved, and the operating room that's there. We started a conference that we put on called Extreme Affordability, where we bring in business and industry, public health, anthropology, law, engineering. And we ask the question, what can we do to make it affordable and available? Again, it's not just about developing a device. How do you implement it into a different society? What's the business model to make it work? We just took this conference to Ghana in July this year and had a wonderful time in eastern Ghana getting the ideas from Africa. Well, this is one of the ideas that you want to use all the connections you have. So I went to the dean of the engineering school at University of Utah. Now, he thought we were coming to talk about my son and my daughter because they were dating each other. I said, no, I need help. Can we design surgery to be affordable in these areas? He sent me over to Bob Hitchcock, director of bioengineering at the University of Utah. He said, there's no marketplace for this. Nope, we can't do that. And then I said, well, what about the example of Jeff Tabin and Dr. Ruitt over in India? They developed a sutureless technique to put in cataract surgery and put in the lens. And then they developed a $4 lens, and then they set up a business in Nepal that mass produces these, and now they're curing blindness all over Central and Southeast Asia, and it's moving over to Africa. He said, what are you talking about? We now have the University of Utah, our bench-to-bedside programs, an exponential rise in targets for developing products that can help disrupt healthcare in low-resource areas. And it's my tenet that those things can come back and disrupt our own healthcare system. We need help in finding the business model to disrupt that. This is one of the things in laparoscopy. The Xenoscope said, can we make laparoscopy more cost-effective? After a few years, some of our bench-to-bedside programs and Dr. Langell came and, using some cell phone technology, developed the Xenoscope. Now, you can see that little box sitting on top of all the big, expensive laparoscopic equipment. What that Xenoscope box, the scope plugs into that, it plugs into a screen. The Xenoscope itself you can make for about $85. It's disposable. Maybe it could be made reusable to make it even more effective. So we went ahead and used this in Mongolia. My program manager says, let's broadcast what we're doing. I said, we can't do that. It's just impossible with internet and electricity. But the Mongolians said, yeah, we can do that. So they put a wire about a mile long, and we broadcast to 44 countries to watch us use the Xenoscope, and we did it in 360 degrees. If you had those Google glasses, you could be right in the operating room with us. We had people call in asking questions from 44 countries. We had the Minister of Health that watched it. She got so excited, she took it over to the Prime Minister. That's what really got them on board for funding laparoscopic surgery. Do you understand what I'm saying? It's not just about teaching surgery, it's engaging the politicians, it's engaging the business people, it's engaging everybody to change healthcare for a population. The benefits of what we can achieve together are profound. Developing surgical services not only generates increased productivity for entire nations, but also mitigates the financial burden to individuals and families of caring for preventable disabilities or death. You know, I mentioned at the beginning that health system strengthening, when we just look at laparoscope, I could put surgery in the middle there instead of just saying minimally invasive surgery. It's an impetus to create new financing mechanisms, provides an avenue for poverty reduction, stimulates infrastructure development. It decreases brain drain. If you develop the infrastructure and teach people how to use it, they stay. If you just go in and teach them how to do a surgery and they don't have the ability to do it, they leave, like in Africa. Opportunity to treat a broader range of diseases, encourages affordable, high-quality innovations. It improves universal health coverage. It strengthens the health system overall. So what I'm talking about is a collective impact. You may have heard collective impact of getting together and partnering and having a greater vision about what we can do. It's not just about making a new device that maybe a lot of people can use. How can we use that device and implement it in a new environment or in a society to have lots of people benefit from it? Now is the time to expand all of our role in discovering and sharing new ways to reduce costs while improving the effectiveness and availability of health care worldwide. Worldwide, even in the low resource areas, even in, you know, I come from Utah. We're not in the frontier, we're not in the rural area, we're in the frontier. There are very rural areas there that don't have access. We have to find ways in our own country to provide access. Downtown Detroit, downtown New York City, but around the world. Previously thought to be inaccessible to 80% of the world's population, timely and appropriate surgical care can actually build communities, it can expand economies, it can save lives, and back to my patient at the beginning, it can engender hope. It gives us hope for a new world, a world where we get rid of these disparities. We find ways to build communities. We provide hope for a new world. The Center for Global Surgery, we define the problem. We explore solutions, hopefully with many of you. We measure our impact. Through this, we're training global leaders that can build surgical capacity through innovation, research, and advocacy. I mentioned that advocacy because it took us 7 years to get a resolution at the World Health Assembly that simply stated in 2015, it was passed by 194 nations unanimously, that surgery should be part of universal health care. I hope we can all be part of this, changing the world, making it a better place. Thank you very much.